Okay, well, welcome to day 2 of the 8th Annual Public Health Research at Maryland Conference. Next slide. The event is made possible by Empowering the State and organized by the University of Maryland School of Public Health in College Park and the University of Maryland School of Medicine in Baltimore. We thank our other event sponsors as well. Next slide. I'd like to introduce our panel for today. The panel is Addressing Wicked Problems in the Current Context, Challenges and Opportunities. Dr. Pinto is one of the co-moderators, along with myself, Dr. Marie Thoma. Our panelists are Dr. Allen, who's the Chief of Programs and Services at the National Association of County and City Health Officials, Dr. Askew, the Deputy Chief Administrative Officer for Health, Human Services, and Education for Prince George's County, Maryland, and Ms. Wilson, the Executive Director of the Maryland Rural Health Association. Okay, I will begin introducing the current context. Let me just share my screen. Wait. Sorry. Okay. So again, we are in the panel for Addressing Wicked Problems in the Current Context, Challenges and Opportunities. And in this session, our panelists will help us build on the theme for this year's Public Health Research Day, Learning from 2020 to Advance the Public's Health. I am Marie Thoma, an assistant professor in the Department of Family Science at the University of Maryland School of Public Health, a reproductive and perinatal epidemiologist, and co-moderator for today's panel. I will begin this session by introducing our panel theme and the panelists for today. As I mentioned, Dr. Allen, Dr. Askew, and Ms. Wilson. And each panelist will then provide their reflections on the challenges, innovations, and needed research that emerged this year. Dr. Pinto, my fellow co-moderator, will then provide an overview of some of the initiatives within the Maryland Health Department and final thoughts. We will then open for questions from the audience, but feel free to post any questions in advance in the Q&A box online. So what constitutes a wicked problem? The general narrative tends to focus on the highly complex and intertwined nature of the problem, a lack of sufficient information on solutions for the problem at hand, or distinct disagreements on the best way forward, which are often characterized by chronic policy failure. And this only perpetuates the persistence of these wicked problems despite considerable attention to these issues. Now, these were just some of the themes that we plan to touch on for last year's Wicked Problems panel, including opioid addiction, diabetes, maternal and infant mortality, cancer, and mental health, to name a few. And at the top of this list, inequities in these outcomes and access to services to address them. But last year's Public Health Research Day was canceled as priorities shifted to the most wickedest of problems, the global pandemic, which not only brought a deadly disease, but also uncertainty, lockdowns, school closures, unemployment, and a redefining of our essential workforce and how we protect them. The speakers on this panel and my fellow co-moderator had to shift priorities within their organizations to address these new problems, while also maintaining support for the other long-standing wicked problems that were only compounded by the pandemic. And it was during this time that the often invisible work of public health became visible to the wider public. However, while COVID-19 is new, the underlying factors that brought us here are not. This includes perpetual underfunding of our public health infrastructure, which leads to an overstretched public health workforce, outdated technology, and states competing for PPE and ventilators. There are also persistent disparities and the factors and policies that drive them. Address them. And here I don't just mean quantitative data, but also the experiences and rich narratives from the communities that we seek to support. In terms of COVID, there was greater visibility of the stark racial disparities in who gets infected, who dies, and who has access to vaccines. Data for the state of Maryland show a higher percentage of COVID-19 cases for Black and Hispanic people compared to the percent of the population that they represent in the state. A higher percentage of COVID-19 deaths for Black people in the state. Whereas there's been a higher percentage of white and Asian people that have been vaccinated compared to the population they represent in Maryland. I will also note that these statistics are not age adjusted, which tend to heighten these disparities further. We're also seeing changing patterns in terms of geographic disparities in COVID deaths within the state, with higher rates in metropolitan areas earlier in the pandemic, but now this has shifted to higher death rates in non-metro areas. And the ability for rural populations to handle these increasing demands is considerable, as we will hear more from our panelists. Pandemic also compounded, we have seen dramatic job losses, which have been much higher for women across race ethnicity groups. There are also stories on the mental health impact on mothers, juggling both work and kids at home. And one sociologist studying families and mothers' role in the pandemic, Jessica Calarco, aptly quoted in an interview, "Other countries have social safety nets, the US has women." Mothers have been a fallback plan for far too long. And yet we seem to wonder why we can't improve our maternal and child health metrics in a system without supportive policies to get there. But mental health has suffered not just among mothers, but the intersection of a lot of other factors. We have seen higher reports of stress and anxiety among lower income households during this time, and among our essential workers, with greater rates of anxiety and depression, substance use, and consideration of suicide compared to non-essential workers. And this is only a snapshot of some of the health impacts in populations most impacted. While this new pandemic raged, the endemic of racism persisted. The summer of 2020 saw the United States' biggest protests for racial justice and civil rights in a generation. This came after the killings of George Floyd, Breonna Taylor, and Ahmaud Arbery, and the many innocent victims before and after them at the hands of law enforcement or civilians acting as such. This brought a renewed focus to our unresolved legacy of racism in our country and in our institutions, and its impact on our health. This spurred many counties and states to declare racism a public health crisis. And just this past week, CDC Director Dr. Walensky announced CDC's initiative to address racism as a public health threat. And with this, it will hopefully bring more visibility, more discourse, more data, and more action to address racism's toll on our public's health. So with this greater visibility and awareness, there are also opportunities to re-envision and rebuild our systems, shift our thinking toward equity, and how we can design new approaches to better tackle these wicked problems, if we are ready to listen. So with that, I turn it over to our panelists. for us to listen to the challenges and opportunities they faced over this past year. And we had posed 3 broad questions for them to reflect on, which were, what are some experiences you have had that have enlightened how we manage healthcare or public health? What are some issues that warrant further study? And what are some challenges that have been exacerbated by the pandemic? So I will now turn it over to Dr. Allen, who will start our discussion.
Thank you very much. Let me get my slides up. So good morning, everyone. My name is Dr. Oscar Allen. I am the Chief of Programs and Services for the National Association of County and City Health Officials. And that is the 3,000 county and city, and needless to say, it's a sizable group of members. And what we try to illustrate here, at least in this particular graphic for the benefit of the audience, is that when you think about health jurisdictions across the country, they're not monolithic. We have home rule states, we have centralized states, and if you really look at the percentage of those jurisdictions that are servicing populations of 500,000 or more, they're only 6% of the public health membership, I would say, even though those large urban centers, are representing over more than half of the population. But there is a vast majority of health departments that are small to medium sized in that capacity, which illustrates, of course, areas of imbalance. And as a colleague just mentioned, there's been significant differences in how public health infrastructure has been supported and financed over the course of time. But just to level set for a minute and recognizing, as I said, I do speak on behalf from a national lens on the work that's done in local health departments. When you think of legal authorities, and there's a reason I'm going to discuss this for a minute, a lot of the times, the power and the legal authorities that a health officer has is by virtue of either state or local-based health statutes. And these examples provide how that health jurisdiction does have the ability to investigate disease, require vaccinations for childhood school-based entries, ban and distribution of tobacco-based products in schools, isolation and quarantines. The best way of saying it, just as you think of law enforcement having police powers, public health also has some elements of police powers as well. And that's where the connection is very important to understand. And of course, for those of you who are in the public health world, you would have seen and be very much acquainted with the 10 essential public health services, which has been redesigned to have a central focus on equity. But in reality, what we call this are the 10 commandments of local public health or public health in general, because this guides the work that is being done on a daily basis and ensures that when you think about how productive and the outcomes that are being driven to improving the health and safety of populations and the goals that are set from an altruistic standpoint, this is what gets people up and excited every day. Now, with that, you can understand that there are challenges that health officials ethically face on a daily basis, whether it's that of individual liberties versus protection of the overall public health, the addressing conflicts of interest, engaging communities so that you can foster trust and reliance on partnership, looking at data and having access to information while at the same time protecting privacy and confidentiality. And as I mentioned, allocating scarce resources because there's so much that's being done with so little at this present time and moment to really support this continuity of effort, and as well as all these other political and other constraints that are going to be important to understand. Now, I say all of that because when we think about COVID and what has been happening, whether it's vaccines or even general, there's another reconciliation that we have really much have to face. And that is the acknowledgement of the historical abuses, the disenfranchisement, and the medical apartheid that has significantly happened in our country that we oftentimes ignore. So, of course, if you know about the story of Henrietta Lacks and the unethical use of her cancer gender determination and taking of ourselves, which single-handedly have advanced science for generations without any acknowledgement, or at least without her permission and her family's permission for that benefit. We've heard so much about the syphilis experiment by the public health services, where individuals who had syphilis, African-American men, were left untreated, even though there were treatment modalities in place, just to see how the disease run its course. But we can even go further back when African women or enslaved African women were experimented on for the sake of Dr. Sims, who was one of the leaders in gynecology in the country and the world, I would say. But his experiments and his colleagues' experiments were on African women who were enslaved in America because of the mindset that they had a higher threshold for pain, or that they weren't human, so therefore they didn't feel the same pain as white individuals. And as a result, we've seen this impact of the exploitation of people of color. And it's not only the African community. We know that Native Americans have been addressing issues about how their health and safety has been jeopardized for the sake of science and research. And even as we've seen similar type of syphilis experiments done in Latin American countries like Guatemala. So when we say contextually, why is it that we have these wicked problems to say, there's a significant area of trust that does come into play, and why the communities have this entire perspective at times that doesn't reconcile with what you may think as, well, I'm a scientist, so they should be able to listen and to understand and participate. We've seen this particularly as we think about the issues of vaccine hesitancy and mis and disinformation that we've through the course of this pandemic, especially when it comes to hesitancy, the perceptions around people of color, communities of color, around distrust of the healthcare sector, and more so the rapid social media and intense spread of bad information that essentially has hampered our progress, as well as significant missteps on the scientific community side of the coin. And I say that because this points to the need for clear and consistent communication, and ensure that we're messaging out, whether it's on vaccine safety, distribution, or the disease as a whole, why it's important to really ensure that we are messaging and communicating consistently in a manner that folks can understand, digest, and absorb. Now, I say that because another particular wicked problem, if I can just illustrate in that way, I'll paint the picture of the vaccination program. In October of last year, states submitted their vaccination plans. And many of them, I would be very, very frank when I say, didn't necessarily integrate local health departments as well as they should. And then we see December 2020, the two lead-in vaccines were approved, and then the rapid deployment of these priority groupings for vaccinations. So by January, many of the health departments were engaged in vaccine delivery systems without necessarily having a significant run-up on having a role to play in the plan and the implementation. Now, I say that not to paint a picture that health departments were ill-equipped, but to actually illustrate one of those wicked problems. For the last 15 to 20 years, we have been engaged from a health perspective in planning and organizing and testing and doing mass vaccination, trials to that extent for the sake of pandemics as well as emergencies. But of course, most of that got thrown out the window when we saw disruption as to how there was a centralized format for how this pandemic was responded to, and the way we were essentially decentralized, for lack of a better word. And as a result, we started to see this realities and the vaccination efforts that really had significant impact, right? The low the very law in handling and storage. Then there was the 2 dose versus 1 dose, the change in guidance, and of course, the hesitancy. And paramount to that, the question and the concerns around equitable allocation. Are we getting it into the hands of those individuals who need it the most, or is it just a matter of a continuation of this disparity that we've seen? Similarly, we recognize that there's another effort around data and how data can be both enacted and provided and supported in a way that really strengthens the need of our communities. And I would say this because speaking as a former health epidemiologist and director of public health planning, we've also seen this significant disparity in the informatics and the data needs that local jurisdictions had at their fingertips and continue to suffer from as a virtue of the disinvestment in public health. I'll put it to you in very plain and simple terms. When the Affordable Care Act was put into place and all these healthcare sectors were getting access to electronic health records, the public health, local public governmental public health were left at the side of the information superhighway holding a bus pass. So that's really illustrating some of the hiccups and the wicked problems that we've seen in having access to data. But what we saw with this pandemic has really continues to illustrate the disparities in race and ethnicity, and even the disparities in how that data is collected and how that data is asked. So we recognize that these are scenarios that drive, solutions that are necessary at the same time that needs to be as unilateral and accessible to all if we're able to make judgments and make informed decisions. We've also seen and I'm using the case study of vaccine distributions, the differences between how elected officials and others sometimes went against what the health and the public safety and the health experts had to say. So it needed both in the identification of those problems, but also in giving guidance as to how to provide clear, consistent messaging, to make sure folks are aligned, to involve the business and private partnerships, and to maybe build that trust and really ensure that the partnerships are strong and maintained to that effect. So here is where I take a pause and just cascade into some other elements that when we asked about what are the experiences and the challenges and where we go from here. Our workforce has been significantly impacted. Public health and especially local health departments, oftentimes we're only viewed upon, well, there's a restaurant, outbreak, and where's the health department? No one really knows what health departments do outside the day-to-day process because they keep their heads down, they do the work, and they move on to the next thing. But we saw immediately this capacity, this need to surge up, this need to get folks, involved and engaged. All of a sudden, everyone in the world knew about contact tracing, something which has been done from time immemorial in public health and wasn't anything new. But all of a sudden, these cottage industries come up because we can do it better, and no one ever really asked in public health. The legal and policy implications. We are seeing, if you remember my first slide about the legal police powers that happened, we know that occurred. We know that several jurisdictions have now been working against public health to reduce their legal impact and their legal authorities, hampering the ability for us to be able to do our work in a way that makes sense. In fact, when you think about it, when you have some states developing policies that said it is illegal for contact tracing to be done, it really belies the common sense approach and the need for training. And as we've seen, the significant impact on support services, as well as our mental and behavioral health concerns for those who are in the field, as well as those that they're serving. I say that because when you think about our landscape, many of us come to public health with a commitment to save lives. We have an altruistic bend to why we are engaged in public health. But many of our staff and our members and our supports were leaving in the wake of direct attacks, harassment, and even death threats and physical harm. We have lost close to 200 state and local health officials in the last year. And this has had a serious impact on our ability to continue and the institutional knowledge that will be necessary for us to come out of this pandemic with at least some even keel. So the opportunities still exist. How do we address the health equity strategy? How do we interface with the public health enterprise and the healthcare sector? Because they're different. And we've seen that with healthcare, community-based organizations, healthcare centers, pharmacies. How do we ensure that the supply and allocations continue to work in a way that really incorporates this data modernization, this improvement of data so that we can make better informed decisions? We don't want all data, but we want quality data, and the need to really beef up the communication and education and the skills that are going to be important to maintain leadership and the development in our careers as we move forth out of this pandemic. Because our future is now. What we've been doing in the past will have to change. By virtue of our experience, we will have to adapt. We will need to look at diversified methods of funding, not just a top-down approach of feds to states to locals. We have to truly embrace the public-private partnerships, whether it's academia, business, or community. We have to focus on those work skills development elements. So as we think about research, not only the fact of the theoretical, but how do we take these things into the applied aspect of the work that we do? Strategic negotiations, conflict resolutions, legislative advocacy. These are items that are going to be important for us to be well-rounded, well-versed, and strengthened as we look to pave the way for the future of public health, whether it includes policy, people, and project management. There's cross-jurisdictional approaches, which I know several of the panelists will discuss, and of course, the need for strong technology support and development. And I will tell you, local acquired data is by far greater contextual need and greater contextual value than what we've been seeing over the course of time. So with that, I thank you. I thank you for the opportunity to be on this panel. And I ask you, during the course of your day, please make sure to thank your local health departments.
Thank you. And we will now turn to Dr. Askew for some of his thoughts and reflections.
Good morning, everyone, and thank you to Dr. Kleiman and all of my other School of Public Health colleagues for the opportunity to share screen time this morning with such an illustrious group of colleagues. It is truly an honor. For background, I am Dr. George Askew. I'm a pediatrician by training, but have been in policy and advocacy work for children and families for quite some time now, before coming to Prince George's County, where I oversee health and human services. Prince George's County, Maryland. I was Deputy Commissioner of Health in New York City, and before that, the Chief Medical Officer in the Administration for Children and Families in the Obama administration. From where I sit, I have had both the pleasure and the pain of being where the rubber hits the road in respect to the public health response to COVID-19. As many of you know, and for those of you who don't, Prince George's is a county of about 1 million residents and is considered to be the most affluent, predominantly Black and Brown county in the country. Overall, we are a county that is over 80% Black and Brown residents. Many of us, I'm a Prince Georgian myself, considered to be essential workers, folks who had to continue throughout the pandemic to continue working. And we also serve as a gateway to the country's national capital region. So we're surrounded by 3 airports. We're right on the border of Washington, D.C., just down the road from Baltimore and New York. And so consequently, we were hit particularly hard by the pandemic with the most cases in Maryland and the second highest number of deaths. So I kind of want to tell you a little bit about my story, of the pandemic, which again is sort of a story of being where the rubber hits the road. And I think you're going to hear some themes that you've already heard from our first 2 presenters being repeated, which just further, I think, confirms that these are our issues. So my story begins in February of last year. I was in New York City. I was already here in Prince George's County doing my current position, but visiting New York for a conference, and was sitting next to a friend and colleague who was the then Commissioner of Health in New York. And at one point, she looks down at her phone, and literally sitting next to me, looks over at me and says, "We're about to announce our first case of COVID." And we both sort of had that sort of somber moment and shared together. And then she looks down at her phone again and says, "And there are going to be a lot more." That meeting ended. This is the end of February. And I came back I should say, and during that meeting, very quickly, there was a a conversation back and forth about PPE use among police officers and frontline healthcare workers. And it was already becoming a problem that we didn't have enough of a resource available. This actually was one of the things that eventually, as Oscar alluded to, our colleagues falling by the wayside eventually led to enough of a disagreements and hardships with the commissioner and the mayor that the commissioner ended up resigning her position in New York. Just one of many examples of the difficulties among public health officials and political and elected officials, frankly, with respect to how we responded to the COVID pandemic. But I'll get back to that later. I then came back to Maryland, where briefed the county council on sort of what steps we should continue taking to plan for when, but when, not if, we would see our first cases. And we soon did see our first cases of COVID, not only in the state, but specifically in Prince George's County. Early on, we saw that Black and brown people were being most impacted by the COVID. And for some reason, something that struck me as strange, everyone acted surprised. Everyone, all of these questions about why are Black and brown people being compromised more by the impact of the pandemic. And I wasn't surprised at all that Black and brown people were being hit harder by COVID in our country, in my county. And I thought neither should anyone else be surprised. We know that from past epidemics, pandemics, national disasters show us that, time and time again, people who are facing the most significant social, economic, and health challenges before the events were the same suffering disproportionately more during the event. Our country's history of structural and institutional racism has gutted the health and human services infrastructure of many communities of color and greatly contributed to the disproportionate incidence of cardiovascular disease, diabetes, obesity, and other morbidities that in a time of a catastrophic event like COVID are magnified. So yes, COVID is an equal opportunity killer. It doesn't care if you're Black or white, rich or poor, Republican or Democrat, but it is also an opportunistic killer. It preys on those least equipped to survive its wrath. And you all know the stories or have or are living it personally or professionally. The COVID response in this country was disorganized and not very strategic at the federal level, and certainly some cases denied that it was even an issue. And that led to problems at the state level, because this was a horrible trickle-down effect. The feds not responding well, leading to the state not being able to respond as well, and then leaving small local health departments basically to figure it out over time, under-resourced, underfunded, in a middle of a pandemic, which, to the scale of which we had not seen in 100 years. Now, we think for the most part, we have figured it out, but it took a lot of hiccups. It took a lot of getting over a lot of hurdles. It took a lot of blood, sweat, and tears. And I literally mean blood, sweat, and tears to get to the point that we are now. And then as we got to the point of having a life-saving vaccine available, our concerns about vaccine distribution efforts became much more focused on the difference between equality and equity. And I'm sure for folks listening on this line, I'm preaching to the choir when I talk about this. Simply stated, equality is about giving everyone equal shares based on a formula that doesn't necessarily take into account where each person, group, or community stands at the beginning of the distribution due to their social, economic, or health issues. With equality, you achieve the same opportunity for success across the board. With equality, you don't achieve the same opportunity for success across the board. And what you do is perpetuate a system by which those who were at the top at the beginning those who are in the middle, and those below the middle will continue to occupy those positions as long as you use a formula that doesn't take into account other key factors to distribute a scarce resource. In this case, it was and is the vaccine. Equity, on the other hand, gives each person, group, or community what they need to achieve success. This may mean that some person, group, or community may receive more than others based on more than what a simple formula might have called for. Now, in our case, in Maryland, what the state did what they thought was the right thing in the beginning, which was using a population-based formula to dole out vaccine. Again, on the face of that would seem to make sense. You've got a greater population, you're going to get more, you've got the next highest, you get the next level, and so on and so forth. But it didn't take into account the disproportionate impact that the COVID pandemic had on a place like Prince George's County and on Prince George's. As I said, we had the most cases and the second most number of deaths in the state. And in addition, were you to account for, as we should, the disproportionate impact the institutional and structural racism historically experienced by communities of color and the current health and economic and social challenges faced by Black and Brown communities, such as those found in Prince George's County, you would have seen plainly that the amount of vaccine reaching Prince George's County was woefully inadequate in the beginning of the response and even in the middle of the vaccine response. And this even included vaccines being distributed not only to the health department, but to our hospital partners who also had maybe even greater infrastructure actually to deliver vaccine because of the nature of their work. Now, it actually took some education of the folks at the highest levels of state government to get them to understand that. And I say the very highest. And certainly, I called upon the state leadership, the county executive called upon the state leadership. And again, I'm talking at the very highest levels. I think people who were sort of working in the trenches kind of got the issue, but we all take our orders from folks whose pay grade is a little bit higher. So again, we called upon that state leadership to review their system of distribution to assure all factors were accounted for in making the decisions about what gets allocated to each county. We also asked officials not to hide behind the veil of hesitancy to disparage communities that were eager and anxious to receive the vaccine. It's very easy to say people don't want it, something that they're not actually getting, than actually taking into account that you're just using that as an excuse. To the governor's credit, eventually put together a vaccine equity task force. I have great respect and admiration for the work that the task force is doing. Communicate with them daily, and things have greatly improved here as we move forward. So very excited about the position we hold now in terms of our ability to address some of the inequities that have cropped up. I wouldn't say cropped up, that have been part of the ongoing response to COVID here in Prince George's County. Now, as we target communities who most need our help during this pandemic, it's like anything else that happens in this country, in my mind. We have very short memories. And I hope we don't remember to forget, we not forget those communities when it's over. These communities that we're making greater investments in and thinking about more clearly will need our investment and attention even more once the pandemic is over. So I'm hoping in the future for catastrophic events, we can address them without the specter of disparity and inequality peering over our shoulders. And that would be a much greater surprise for me. We were specifically asked to talk about a few questions that were put to us. And I'll just quickly sort of point out just really quick some of the things. What are the experiences you have had that have enlightened how we manage healthcare or public health? I think what we found is that prior partnering and partnerships proved to be the most successful during the pandemic. So again, where we had partnerships with entities within government, within the private sector where we were already sharing information and meeting. We were able to move much faster with those folks than trying to establish new partnerships in the midst of a pandemic. Some of the more challenging pieces were, we're investing now, but we really haven't learned our lessons regarding support of health and human services. As Oscar was pointing out, people kind of forget what we do and what happens in the background, because when we're doing our job well, people remain healthy and safe. When an emergency happens, I always say about our health department, we had a great starting lineup, but we didn't have a bench because we didn't have resources. So if people go down, if you have one epidemiologist in your department and that person goes down, there's no other resource to make that up. So again, what I'm hoping is that we don't see that our memories are short and repeats itself on remembering where we were leading into this pandemic. Also, some of the big picture stuff, we're a zero risk tolerance country that also demands a lot of freedom of choice. When trying to make tough decisions about resources and who gets what, and how much of what you get, people don't have very much patience for not receiving scarce resources in this country, and also demand their ability to make their own choices, even if it might not be in the greater public interest, a challenge that's hard to overcome. Oscar pointed out, that the public health community is currently at great risk, I think, and has become all too often the scapegoat for failed planning. I've had numerous colleagues who have fallen by the wayside across the country. As I was, I'd written this before, I said, I don't have the data, but a significant challenge moving forward. Well, Oscar had the data, and you can see just how many folks have fallen by the wayside for a mix of reasons, but many of the reasons being someone had to have the finger pointed at them for this happening in a way that didn't work well, and a lot of them were public health folks. We were asking, what are some of the issues that warrant further study? In general, I'm not a big fan of what needs further study. We've studied so many different things in this country. As an advocate for many years, I've always said, we have all the data. Now let's turn things into action. So sometimes more research gets in the way of action. But I think one of the things that's most warranted is detailing equity successes. Where did it work well, and what factors had to be in play? What were the political motivations? What were the things so that when we have such a situation again, we don't rewriting the playbook is all set for us. And finally, what were some of the challenges that have been exacerbated by the pandemic? I think I mentioned the issue of equity and a real understanding of what equity means. It's not equal, it's equitable. The disinvestments in health and human services and communities of color has really come home to roost, and we have to pay closer attention to that as we come out of the pandemic and leading into the future. And finally, I still think folks don't quite broadly understand the magnitude of this challenge. This is a worldwide pandemic viral outbreak that is going to take and is taking an enormous level of work and planning, and unexpectedly having to do so. And patience is not something that folks have a whole lot of, but understanding what actually has to happen. If you're thinking about community immunity throughout the world, the number of people that have to receive a new vaccine over the course of a short period of time to make community immunity a reality is a daunting task. So I'll stop there and save the rest of my time for comments later.
Great, thank you so much. And I will now turn it over to Ms. Wilson.
Great. Well, thank you all so much for the opportunity. I'm excited to share a little bit with you from the rural perspective. I think that it's been really great to hear the national perspective, the health department perspective. And I just wanted to take a second to introduce. So I'm Laura Wilson. I'm the executive director for the Maryland Rural Health Association. And we're a nonprofit organization, and our mission is to educate and advocate for the optimal health and wellness of rural communities and their residents. I thought I would start right here just to show, so this is obviously the map of Maryland. The green counties are what the state of Maryland indicates as rural. So very green map. And again, it's 75% of our state in terms of land mass, but only about 25% of our population. This is very similar to the country as a whole in terms of rurality. And I'll also just pause really quickly to mention that while the state recognizes these 18 of 24 jurisdictions as rural, there are varying different federal definitions. The HRSA organization has one definition of rural, the CMS and CDC and the Census, USDA, lots of different definitions of rural, which comes into grant making and access and support and resources and resource allocation when it comes to funding, just in general, but also when we're talking about the pandemic and resource allocation. So I think that it's just interesting. Most of our work is within the state, and so we do use this definition, but it definitely varies depending on the project and the conversation. So just a quick kind of history. Back in 2018, we published a report on the rural, oops, sorry, my mouse is doing funny things, on the health of rural Maryland. And so we partnered with the State Office of Rural Health, the Rural Maryland Council, and the Robert Wood Johnson Foundation. And we went to each of the 18 of the 24 jurisdictions, and we did groups with providers and consumers. We collected data, and we put together a list of resources that highlighted some of the rural health challenges. And talking about the challenges in different communities, one of the reasons that we wanted to do this project is, especially when it comes to funding, when it comes to laws being made, legislation being passed, there's a lot of efforts focused on the cities and Baltimore's and communities that have a lot of people. And so we thought this report would be helpful to be able to bring it to our lawmakers and remind just people in the higher levels, you know, again, about the challenges that our rural communities face. We also have all this data on our website. We have this website that shares that data if you're interested. But here were the top 6 kind of rural health challenges that we identified through the Rural Health Plan. Number 1 is access to care. Obviously, that's a broad statement. And as you'll see later, some of those access challenges really highlight around behavioral health, which has become exacerbated during the pandemic. But sustainability of funding for healthcare services, that continues to be a challenge. Care coordination, whether even if there is access to services, helping patients access those services, coordinate their care, get from one step to the next, chronic disease prevention and management. And then there's literacy and health insurance literacy. Number 1, understanding what your health challenges are. And then do you have health insurance? Do you have enough health insurance? If you have health insurance, what does that health insurance mean for you, and what can that do for you? And then general outreach and education. One of the things that we hear a lot is, and kind of has been mentioned before, there's this health department. It's in our community. What are the services they're providing? Making sure that the community is aware of those services. I use, we've had several speakers, but that's just one example. So going to this next slide, this has a lot of information, and I knew that putting it up here, but the reason I wanted to put this up here is twofold. Number 1, on the right side of your screen, these are the Maryland Rural Health Association's vital partners. Now, I mentioned that we were a nonprofit organization, but we're also a membership organization. So some of these partners include some of our members. So the local health departments, the area health education centers, the federally qualified health centers, the State Office of Rural Health, the Rural Maryland Council, who's in our state, the Community Health Resources Commission, the Behavioral Health Coalition. That's really important. Maryland Citizen, I'm not going to read them all, but it's the hospitals, the health departments, the small clinics, the concerned citizens, a lot of different partners that come to the table that care about rural health, telehealth, urgent care. Again, not going to list them all, but I wanted to show this because every year our organization speaks up and supports legislation in the state of Maryland that might impact rural health. and it doesn't always sound or cover issues that you think it might come from, behavioral health to supporting crisis intervention services, from community community health workers, community providers, access to services. And I will mention too, there's oral health that's also been a huge area of concern and impact in a lot of ways. And I'll also mention here that when we're talking about health services, that doesn't just mean somatic care, going to see your primary care physician. That means housing, nutrition, access to healthy foods, and all of those social determinants. So just wanted to pause there. Again, I know that's a lot of information. So then here we are with COVID-19, the pandemic, and the challenges. Again, so just really quickly, I actually saw this slide earlier today, so we're not going to spend too much time when Dr. Thoma was talking. But here, I think I wanted to put this up because I think it's very interesting to see that while that blue line, there was those early spikes of deaths from COVID-19 in the beginning, and then as the time went on and the pandemic changed, those spikes happened in the rural areas, and that was actually seen specifically in our state, in Garrett County, where their numbers were extremely low. And then in the fall, they started spiking, and it was a really it was challenging, not only for that community, but it was hard to manage because things were constantly changing. So I just think that's an interesting to see. Again, there are so many factors that contributed to the spread of the virus. Underlying health status, those socioeconomic vulnerability, access again is a main challenge, and just overall compliance with public health guidelines. So not surprisingly, rural communities face challenges that make them more vulnerable. Rural versus urban, 24% of rural citizens have a low socioeconomic status, as a 22% higher poverty rate, 19% more food insecurity, and 15% uninsured. You put these all together, there's going to be challenges when there's a public health crisis. And that was seen in terms of many of the access challenges and to the pandemic. And then again, kind of to overall kind of highlight how this impacts our rural residents, there are underlying health conditions. There's fewer healthcare access points, not just fewer hospitals, fewer primary care providers, fewer FQHCs, fewer urgent care centers. And so that's a challenge when you're trying to access services, especially when people are homebound and trying to determine how to get the care that they need. Overall provider shortages in our rural communities and longer travel times. The nearest hospital be an hour or more. The closest urgent care center could be 30 minutes or more, or an hour. And that's just when managing the pandemic and trying to provide care for patients, it's a large challenge. I thought this was an interesting slide to be able to show that rural residents are more likely to have factors that exacerbate COVID-19, and you can see the dark black circle is the urban communities, and then the blue circle is how much greater the risk factor of communities compared to the urban counties. Obviously, COPD was here the greatest, but all of these challenges are just exacerbated in our rural communities, which impacts the effects of COVID-19. And then here, talking about mental health, you can see the statistics. 3 in 5 rural adults say that COVID-19, the pandemic, impacted their mental health. I'm sure all of us in some way, shape, or form have felt this impact. 2/3 of rural adults say that they're facing more mental health challenges. In communities where there are limited behavioral health services, when 2/3 of rural adults are experiencing additional mental health challenges, this becomes an even greater challenge to access services. And then 45% of rural adults say stress and mental health has become more of a problem in their community. It's an 8% increase. So, and I know we talked about this, the rural vaccine and challenges. There's access and there's hesitancy. I agree. You can't just blame the challenges on the hesitancy. You have to be able to get people to receive shots in their arm. But as you can see here, there's lots of different challenges and lots of different communities. But rural residents, 8 times more likely than urban residents to lack broadband, to be able to get that access, to get that appointment. And then here we talk about telehealth too, 34% lower adoption of telehealth. So that's one piece, but then you have to actually physically get somewhere to get your vaccine. And that 51% of rural patients for the transportation is a barrier to get their vaccine. And then there's also the hesitancy factor. Rural residents are 1.2 times less likely than urban residents to indicate that they would want a vaccine. Side effects is a factor. And then here we talk about that mistrust again, significant mistrust of the safety and efficacy of the vaccine. So here are some challenges. So that concludes my portion of the presentation. I know we'll have some time for questions later, but thank you again. And I look forward to the continued conversation.
Thank you. Now, following hers, we will open up for Q&A. And just a reminder, if you have questions, feel free to put them in the Q&A box as well.
Good morning, everyone. I hope you can hear me. Thank you to all of our panelists. That was a great presentation about all of the different types of challenges and issues that we're facing as a state and as a country related to the COVID pandemic. What I would like to do now is kind of step back just a little bit to talk that Maryland is putting in place and that we are implementing that not only should address over time some of the things that some of our panelists have already presented, but really to talk about how it is that so far Maryland has been working to evolve our healthcare delivery system in ways that going forward, we should be able to address some of these issues of challenges related to equities and disparities. So first of all, I'd like to talk a little bit about population health in general and review some of the key principles of population health, and then give some examples of how different population health interventions are underway in Maryland related to some healthcare financing innovations that Maryland has been involved in, most notably our total cost of care all-payer model, as well as our statewide integrated health improvement strategy. So when we talk about population health, it's a term that has become very popular in recent years, but there's many different definitions and many different ways that people view population health. So when you think about clinicians, population health to them mainly means the patients that they take care of on a regular basis. But in public health, when we talk about population health, we think about the health outcomes of a group of individuals, and that group could be a particular catchment area for a hospital. It could be an entire way to differential healthcare outcomes. And so to improve the health of populations, we both have to look at clinical management of individuals in the group, as well as address these underlying determinants of health status across the group. And the graphic that you see here on the slide is from the county health rankings model, which really talks about this continuum from policies and programs to addressing healthcare factors to then lead to particular health outcomes. And what's really important to notice in this graphic is that we see that clinical care really only contributes about 20% to the types of population health outcomes that we see. And when we think about the fact that social and economic factors represent 40% and that health behaviors represent 30%, what you can see is that this model and this data and these findings really support all the information that we have already heard from our previous panelists. Now, how do we get to looking at those different factors and then put in programs and processes to address the factors? Sorry, I need to go back a slide. So the key elements of population health improvement are represented here on this slide. So what we need to do is we need to look at those health outcomes. We need to look at the patterns of health determinants, and then we need to implement policies and interventions that are responsive. And so again, thinking about data, we collect and we prioritize data and measurement, but we also have to understand data that really identifies and can show the health determinants and the disparities and the inequities that we have talked about. Now, we heard Dr. Askew say, we don't really need to do any more studies. We have a lot of evidence, and that is absolutely true. However, there are pockets of either people, groups, or areas where showing data in black and white really sometimes does paint a picture that can allow people to better understand not only the specific underlying factors that need to be determined, but also then can be used to identify evidence-based programs. Again, going back to that model where it talked about economic factors being an important part of determining health outcomes, one of the most important concepts that has emerged over many years, I think that we all have understood this through our careers, but there's a term now that is used and that it actually is now translated into clinical practice, and that is called social determinants of health. And then in deploying evidence-based programs, not only is it important for us to be able to deploy these programs, but again, the pandemic has shown that the public health infrastructure and interventions need to be able to be nimble enough to be able to adjust to emerging threats, as well as data that shows that perhaps programs are not necessarily addressing needs appropriately or moving in the right direction. So I wanted to highlight to the group a couple of different innovations that have been moving forward in Maryland to address this overall population health model. So you may have heard people talk about Maryland's all-payer model. And this all-payer model is something that is unique to Maryland. And it began in 2014. And the model served to shift the focus of healthcare delivery and financing from a cost per case, where you may have heard people talk about a fee-for-service model where providers are paid by volume of patients that they see. And it was to shift that model to a more population-based and also the 4 years between 2014 and 2018 looked at per capita value-based payment frameworks and looked at provider-led efforts to reduce avoidable hospital use and hospital emergency department use, and looked at improving quality and coordination of care within the clinical settings. We also talked about saving Medicare dollars without cost shifting and incurring any additional risk on the part of clinicians. And some of the models that were put in place were designed to strengthen rural healthcare with some sustainable revenue base by supporting different payment structures to incentivize rural healthcare providers, as well as rural hospitals. So this all-payer model, looking at global budgets, looking at sustainable growth to have that growth be reduced in terms of healthcare costs, and to then move into population-centered measures and targets for improving healthcare. Now, back in 2018, this all-payer model shifted yet again. And rather than look at just being an all-payer model and looking at models that are still related to focusing on hospitals and hospital savings and quality, we changed the model to evolve into what is called a total cost of care model. So this new model looks at the healthcare delivery system as a whole. It looks at the total cost of care, not just on the clinical side, but total cost overall, and looks at hospital quality as it relates to improvements in certain population health outcomes. And this, again, is just a trajectory that talks about some of the model targets. And in the interest of time, I'm going to go ahead and skip this slide and move to the specific model strategies, which is to foster accountability, both in the healthcare delivery system, as well as the way in which healthcare delivery uses non-traditional partners for getting better healthcare outcome, to align incentives, to transfer care, and to improve the population. So one of the ways in which we are doing this is through looking at what's called the statewide integrated health improvement strategy, which really looks at how do you align the total population health, hospital quality, and transforming all of this healthcare delivery system across the healthcare delivery system. Now, the goals related to the total cost of care model and our statewide goals are in three different priority areas. One is diabetes, the second is opioids, and the third is maternal and child health. And diabetes has been the first program that we have launched related to trying to meet certain targets that were negotiated by the federal government and the state of Maryland to try and improve the outcomes related to people with diabetes. Diabetes was chosen because it was the #1 healthcare issue that had an extremely high total cost of care prior to the implementation of this model. Approximately 1.6 million Marylanders have pre-diabetes, and 9 out of 10 don't even know that they have it. About 500,000 Maryland adults have diabetes, and it's the 6th leading cause of death. And what we know is that there is a $2 billion loss of economic productivity as a result of prediabetes and diabetes. And we also know that 2 to 3 times higher estimated healthcare costs are for people with diabetes. So when it comes to COVID, I think that one of the things that was highlighted at the beginning of the COVID pandemic was that there were certain chronic health conditions that made people more at risk for death or severe cases of COVID-19. And diabetes was one of those. So people with diabetes had 3 times higher severity of disease. They had more hospitalization, more admissions to intensive care, and more death than those without diabetes. And 1 in 10 people with COVID-19 with diabetes died within 7 days of admission, and 1 in 5 needed mechanical ventilation within 7 days. And when you think about the way in which diabetes affects Marylanders, and you think about some of the healthcare resources, say in rural areas, this issue about ventilators and the need for people with diabetes to have ventilators, as well as people with other chronic conditions such as COPD, this became a very, very significant issue, to the point where the federal government invested additional dollars in rural hospitals in order to get them to have the access to additional ventilators. Maryland is in the process of implementing a diabetes action plan, which is posted on our website, which really takes into consideration how we can partner through public-private partnerships, work with community groups, employers, as well as insurance payers to implement a spectrum of interventions that would address the issue that we want to reduce the incidence of diabetes and really focus on people who have pre-diabetes to prevent them from developing diabetes, as well as look at people who are at risk of pre-diabetes, say people with overweight, obesity, to try and prevent them from developing pre-diabetes. So within this diabetes action plan, there are many different actions that the Maryland Department of Health is currently employing to bring stakeholders to the table with very intensive discussions about how to partner with all the stakeholders to implement different mechanisms for addressing diabetes. One of the highlighted programs is the use of community health workers. And I don't really have time in this presentation to speak specifically about community health workers, but community health workers is one of the types of sort of non-traditional yet historically valuable providers to address this issue of diabetes. And with that, I'm going to end my presentation and turn it back to Dr. Thoma for us to begin to entertain some of the questions that you all have posted in the chat box.
Well, thank you to Dr. Pinto and our panelists for these enlightening discussions. I am just checking the Q&A box, which I actually don't see any questions. So if you have questions, please post them now. I have written a few questions down as our panelists were discussing. And I think the first one that I had, and I think this can apply to all, but it was mentioned by Dr. Allen, was you know, the public health workforce and strengthening the public health workforce and work skills development. You know, as a school of public health here, what are some of the skills that you find that we could train our students in that you would need within some of the local health departments? And well, I'll leave it to you to kind of expand, but just what are some of those work skills that might be needed in this post, still dealing with the pandemic, but post-pandemic as well?
Sure, and I know Dr. Askew probably has additional bunch from his extensive experience as well as probably other panelists. So I would say a couple of things. In the world of contact tracing, it's more than just can you take that information, but the people skills, the ability to talk to individuals, especially when you're ascertaining health information to that extent. So any of the skills that provide that kind of people-to-people interaction, which allows folks to, it's more than just say, hey, I'm calling you because you were, or I'm
I think we froze.
I'm not sure what happened. So I'm assuming that he will eventually realize that he got frozen, but in the interest of time.
We could also ask Dr. Askew, maybe.
Yes.
Sure, I will first of all agree with where Dr. Allen was going, particularly with respect to issues like customer service and front-facing and public-facing positions within public health have turned out to be critical, and as well as where we get a lot of the complaints from folks. Folks who are stressed. We've been at this for well over a year. Learning to be able to, or being trained as part of your professional development to interact with the public, particularly under stressful situations, is critical. The other thing that I would add, just off the top of my head, is cross training. And I know, when you're in academic training, you're getting a wide breadth of experience. But the broader the experience that people can get in their training, the more valuable they become in situations like this. We've run into situations where we've had people to have to take on new jobs and new responsibilities, and the folks who were the most valuable were those who had the greatest breadth in their training and experience coming into this setting. And I do want to make one other thing. I want to make sure folks know I am not against research by any means. I am a strong proponent of research. Research that quickly leads to action is, I think, more along the lines of what I was really trying to get across, and using some of the research that we've already done to bring that to bear on action items is what I was promoting.
Thank you, Dr. Askew. So I actually also have a question for Dr. Askew and Dr. Allen. So in the framework of population health, one of the most important concepts is that population health is really operating where clinical practice and public health intersect. And so what do you see in terms of from your vantage point, have been some of the challenges in getting clinical practitioners and public health practitioners working together?
You know, one of the biggest issues has actually been on the IT side. Having systems that don't communicate with each other, or folks being on so many different platforms, makes it difficult to manage some of the most, as for making data-based, evidence-based decisions. Being all on the same platform is truly helpful. One of the things that I mentioned during my presentation was that the partnerships that were formed beforehand proved to be the ones that were the most fruitful during the pandemic. And the example I use is it was literally in January of 2020 that we scheduled our first meeting with all of our hospital partners. So every lead from the hospitals that serve Prince George's County was invited to a meeting with me, the county executive, and we began to just share ideas, not COVID related ideas. We weren't talking about that. It was early January. We were talking about other issues that we wanted to face within the county, and we sort of asked, or I asked the hospital leadership to sort of lay themselves bare and be transparent. And it's very difficult for systems and with other systems in the room to talk about challenges, to talk about where they want to go, what their planning is, what the because in some respects they're competitors. They have a double bottom line. They want to do well and do good at the same time. They have to respond to boards of boards. They have to respond to other stakeholders. But having that meeting in January, when we had to come back together, I think we came back together in March, there was already a sense of collaboration that existed between the public health sector and the private sector, at least among those providers. And we continue to meet regularly since then, and has been one of the most fruitful. And I think one of the, I hear from our hospital partners that they don't hear of any place else in the country where this is happening, where the hospital systems who are facing challenges of their own are meeting regularly with the public health sector to figure it out as a team. And so that's been really helpful.
Great, thank you. Dr. Allen has rejoined us, so I don't know, Dr. Allen, if you want to continue with your response to the previous question.
Yeah, I'm sorry about that. My internet went down at the wrong time. So the couple of things as far as the training and the expertise that will be important. As I was mentioning, the ability to do both patient level or individual interviews and communication, those elements are going to be important. The data management, project management, because there's so many different projects that are coming into play, that the ability for folks to really navigate all those particular waters to make sure deliverables are being met, deliverables can be addressed. From a workforce capacity, anything that allows, I think many of our members are looking for both individuals to look at data in a way that gives them the information to be digestible, both from the community standpoint, as well as for decision making, and also the various allied health professionals that exist. I know a lot of people tend to focus on nurses, et cetera, but there's a significant need around integrating both communication strategies, behavioral health, social services, all these aspects that tie into this entire facet of what it means to be an integrated health system. So there are those skills that are going to be highly marketable to the extent that would allow students, early career professionals to really get in on the ground floor and to have some immediate benefit to the public health workforce, and recognizing that there's a continuation of effort to maintain visibility and at least have some we'll call it continuing education, but making sure that we're on the cutting edge, or we're on the forward perspective. And language, especially thinking about from an equitable standpoint, language skills are always going to be highly treasured in the workforce.
Thank you. Ms. Wilson, would you like to answer that same question as well from a rural perspective?
Sure. I think that it's really important to consider just all those different factors in terms of engaging both just different populations. So I think that I don't have too much new or different to add, but I think that our vulnerable populations, there's different types of vulnerability, and I think that ensuring that consideration is given and those considerations are made for our populations is just really important during these crisis situations. So those are my only thoughts on that right now.
Great, thank you. One other question that came into the chat box is, how can health literacy change the perspectives of those who are very apprehensive to trust health departments? How can we as a school start to implement health literacy to communicate to our community? And I will ask any one of the panelists who'd like to answer that question.
Sure, I can start. Certainly, we want to do all that we can to make the folks that we're working with in the communities better consumers, so that they know what sites are reliable, what information is most reliable. What we're finding more than anything else in terms of health literacy is it's word of mouth, and more than anything else, it's folks who have participated in some respects with vaccine or have had conversations with their providers where they're able to ask the right questions so that they come away feeling comfortable or at least knowledgeable enough so that they can make well-informed decisions. So each and every person, and it's not just what we're learning in the classroom, but what we're also saying to our friends and colleagues that makes a big difference as a trusted voice. And also making sure that our folks who are involved in health literacy education understand who the trusted voices are in communities. We've done a lot of work on trying to make sure that the trusted voices in the community are also the folks who we're engaging with, so that residents who go to them, barbers, clergy, and as I said, the person who runs the local bodega, those are the folks who actually have as much, if not more, influence than any of us who are in the field itself.
Laurie, okay, pregnant pause. I was going to jump in, but I didn't want to give deference. To further add to that, I think there's an understanding that, and I'll just say from the workforce capacity, when I was a local health epidemiologist, I had about 120 people on staff, not as the total health department. We served a population of 311,000. As Dr. Askew's mentioned, serving a population of 1 million, he doesn't have one person for every individual in his county that he's able to interact. So you are always going to need to amplify your reach to the community base and those trusted ambassadors that are within, whether it's the business, the community, or whatever entities. So health literacy, is important, and what it has taught us, we can't just rely on a billboard to get the job done, right? People are our business. People are how we interact and how we really get, our outcomes. So it's going to be very helpful to really engage both in that community-driven efforts and not just say things need to be at a grade school level or a grade 3 level or 4, but really understand and meeting people where they are, amplifying their understanding so that they can digest the information, absorb it as their own, and take that and be able to amplify it in the community.
So we have time for one last question. And I wasn't sure if Ms. Wilson, you wanted to add to that because you talked about health literacy as a key element for rural populations. And if not, I have another follow-up question as well.
You can ask your question and I can touch on health literacy as well.
Both. Well, maybe this relates, but I feel like you had also talked about challenges with telehealth delivery and services. And I found that some of the rhetoric has been, oh, telehealth has met a lot of demands during this time, but in rural areas that hasn't, well, in many areas, not just rural, but I think I've heard discussed a lot as a challenge in rural areas, and even some of the shift to like teleeducation that schools have had to do have been particularly challenging. I don't know if you could speak to that a bit, and maybe even some of the solutions that you've come across.
Yeah, so absolutely one of the I don't want to say silver linings, but one of the positives that has come through the challenges that we faced during COVID-19 has been the launch of telehealth to a level that has never been seen before. It's probably the single greatest launch in the utilization of telehealth. A lot of that was because restrictions on reimbursement were significantly relaxed. And so reimbursement, doctors' offices didn't have to worry about whether they were going to be reimbursed. They could see their patients. So from that perspective, it really did launch it. And it's a wonderful option for our rural communities. That's with the if and only if there is access. Those challenges in terms of access and compounded with the school system and with children not being able to be in school. A lot of solutions in terms of there's mobile hotspots. The largest challenges in our rural communities is there's no broadband. There's a lot of broadband interstate, but it's not that last mile, and people being able to connect to that broadband. But broadband is one piece, and then there's just cellular service. So providing a mobile hotspot is only as good as that cellular service. And some of the solutions that used to be options, go to your local public library to receive, to get internet, that was closed. So oftentimes people were driving to the parking lot of a school to be able to get access. So they couldn't get access to their health department. The schools were still providing the Wi-Fi, so they would drive to, if they have a car, drive to a parking lot to be able to tap into that. So, and then in terms of, so I would say that while yes, telehealth has been a great solution, without additional resources put to extending those services into the rural communities, it's not going to be able to close all of those gaps. And I think that that's something that additional funding, and I've seen that the state is now allocating additional fundings. I think it's a priority. I think that if in the future, if there are for future public health emergencies, if the world is going to go virtual again, and talking about equitable, you need to be able to have those services be available to everybody, regardless of where they live in the state, whether they're close to a city or not. So I hope that answers your question.
Thank you.
You're welcome.
Great. Well, thank you, everyone. We are going to go ahead and close our session now. We would like to thank you very much for joining us this morning. And the next session for the conference will begin at 11:30. We would like, and that session is physical activity from vision to implementation. We would like to make sure that each of you remembers to fill out your evaluation for the session, and the evaluation form can be found at the link which is shown here on the slide. And with that, we would thank you very much, and we wish you a good rest of your day.